Well, thank you for the opportunity to present to you guys. As Caitlin mentioned, I'm interested in complex high-risk percutaneous intervention. I want to show you a case that Dr. Jennifer Trimmel and I did just last week for a patient in this field. I have no relevant disclosures, and the three things I want to go over with you with this case are, number one, I want to discuss the clinical evidence behind mechanical circulatory support assisted complex PCI and its appropriate use in the appropriate clinical setting. Number two is to talk about the role of intracoronary imaging in this field and review some of the recent data that was just published. And then lastly, I want to talk about all the cool tools that we get to use as interventionalists for this particular field in terms of trying to have a successful lesion preparation, and so to improve our technical outcomes and know kind of some of the advantages and disadvantages of each tools and when to use them. We'll start with our case. This is a patient Dr. Trimmel and I met last week. She's 81 years old. She's quite sick. She has hypertension, hyperlipidemia, insulin-dependent diabetes. She had a history of stroke, and she's on dialysis. And she recently just had a STEMI about a week prior to, so 2 weeks ago, so a week prior to her admissions here, and her trope peaked at 12,000. This is high sensitivity trope. She was found to have new systolic heart failure, EF in the 37%. And during her workup, she was found to have multivessel CAD, which I'll show you the diagnostic angiogram in just a second. She was deemed not a surgical candidate for revascularization due to multitude of things, including her advanced age, her comorbidities, her functional status, and possible workup for malignancy. But the family and, of course, the patient wished to pursue percutaneous revascularization. You can see the transthoracic ultrasound here, which showed that she had normal LV size. Her EF is about 37%. She has septal apical akinesis, and she has anterior wall hypokinesis. This is her diagnostic angiogram. This is our AO view, which showed that we have pretty diabetic diseased vessels that you can see. Her left circ is pretty small, diffusely diseased. She has this tight lesion that you can almost see just in the caudal view right here, but you'll see better in the cranial view. And if you look actually closer, she has a distal left main disease. You can also see that this she's got pretty calcific disease. You can see the outline of her vessels even before the contrast. This is the cranial view. You can see that she actually has serial lesions in proximal to mid LADs, pretty calcific, 90% proximal, about 80%, 70, 80% mid. And then you can see the distal left main just a little better. The right side, initially you see that she's right dominant, 20, 30% mid RCA. But if you look closely, she actually has this chunk of calcium right here. Right here, causing severe osteo-RCA disease. Her hospital course, unfortunately, took a worse turn. In the morning, she had recurrent crushing chest pain. She was more altered, and she had an episode of emesis. Her blood pressure is hypotensive. She's more hypoxic. Her ECG showed that she had new left bundle branch block, which makes you worry about almost a STEMI equivalent. Her tele showed that she had frequent NSVTs. And actually one sustained VT episode. RT code blue was called. She was intubated for airway protection. Her labs during this time later came back that her trope was off the chart. Lactate was elevated. The primary team that knows her the best deemed that she was not a candidate for ECMO or emergency bypass. So she arrived to the cath lab where I met her for the first time, intubated on high doses of epi and boluses of epi with very tenuous hemodynamics. So our plan is to stabilize her first. We chose Impella CP as our mechanical circulatory support device for cardiogenic shock and also for protected PCI. We knew that we need to work. We knew what her arteries look like, and we need to open up the left main LAD. What I mean by protected PCI is that the use of mechanical circulatory support agents like balloon pump, Impella, tandem heart, which we don't usually use too much here, but mainly just balloon pump and Impella in high-risk individuals. I think for our particular patient, she was also indicated for her worsening hemodynamic instability and cardiogenic shock, but for the term protected PCI actually means sometimes an elective use of this before the patient becomes hemodynamically unstable. And this is for high-risk PCI, including unprotected left main, if you have the last remaining conduit of PCI, or if you just had really, really bad EF and undergoing a PCI, that is the vessel that is supplying the majority of the remaining heart, or patients in cardiogenic shock. What are the evidence behind protective PCI? So for balloon pump, there's really only one clinical trial out there, which unfortunately show no difference in 6 months composite outcome mortality. However, there's a little bit of differences in procedural complications. So as you can imagine, people who have elective balloon pump use have less procedural-related hypotension, ventricular arrhythmias, and cardiac pulmonary arrest. That's 1.3 to 10%, and about 2% of the patients who did not have upfront use of balloon pump bailed out and actually used the balloon pump for mostly procedural hypotension. But you have to trade, kind of your trade-off is the potential risk of bleeding and access site complication. There is a meta-analysis that looked at balloon pump in STEMI patients, unfortunately did not show improved outcome or hard outcomes. What about Impella? Impella has a series of trials that's named as the PROTECT trial. So PROTECT 1 said, hey, we can use Impella 2.5 in high-risk PCI. It's safe, easy to implant, and hemodynamically effective. And 2 was meant to show that it's better than balloon pump, but unfortunately it did not in terms of 30-day major adverse events, and you can see the composite score up there. Unfortunately, no difference in the trial had to be stopped early. 3 is an ongoing FDA post-approval registry that so far I think have more than 1,000 patients, and this is for elective non-emergent PCI with Impella and Impella 2.5 and Impella CP. When they compare that, this was presented in TCT 2019, maybe there is a statistical difference compared to a balloon pump. And of these 1,000 plus patients, 494 patients are PROTECT 2 trial-like patients, meaning that they're a little bit more higher risk. And then what we're really waiting for is the PROTECT 4 trial that hopefully will give us a little bit more definitive answer. This is a randomized trial that will look at Impella CP compared to control, which means that they have no MCS up front or they have balloon pump. And what they're looking for is a composite rate of all-cause death, stroke, MI, CV hospitalization in the follow-up 1, 6, 12, 24, and 36 months, and then follow-up for 3 years. So to be determined. So the summary is so far our evidence about level C, which is not terribly robust, but the guidelines so far actually still give us a class 2B indication, saying that, look, it's reasonable for these high-risk patients, and it should be determined by case. And I think particularly for our patient, I mean, she was really, really unstable, and there was no way that we were going to be able to do such a complex left main LAD PCI without the hemodynamic support. So back to our patient, I quickly look at her CT that she had prior. We know she had adequate iliofemoral access. This was a femoral angiogram that was done just recently prior to our case. You can see she does have peripheral vascular disease and really poor flow in the FSFA. So it makes you think about perfusion later after her PCI, especially if she was not going to be weaned off of Impella right away. We did our usual micropuncture technique under ultrasound, confirmed by fluoroscopy and then femoral angiogram, looking like this is a pretty good access puncture. We want to do that because we want to be meticulous for that because, as you know, this is a 14 French, a pretty big arterial access, and we really want to make sure that we did the right thing before we upsize it to the 14 French. This is a still frame shot on the left-hand side, which you can see the Impella is in place. And this is actually a little later because you can see we have our coronary wires in the left circuit LAD. And then you can see the TEE intraoperatively showing that this is in the adequate spot. And the upper right-hand corner, you see this is actually a real screenshot of her. Our perfusion was able to take a picture for me. She was pulling about 3.6 to 3.8 liters per minute of cardiac output, and her maps improved from, I don't know, maybe 30s to 80s and 90s, which the anesthesiology team is very happy about. And, you know, everybody can just take a breath, and now we can really focus on important procedure, which is the PCI. We decided that we'll do a single access. The actual pump for the Impella is 14 French, but after the pump is in the heart, the sheath is actually smaller. So we can actually accommodate up to a 7 French sheath. So we can use this 7 French for most of our PCIs, including rotational atherectomy if we need to use it. So I think with every percutaneous intervention, there should be a systematic, methodical, and thoughtful approach to things. In my head, I have my own algorithm, but I'm sure different attendees have different kind of things to think about. We talked about lesion, we talked about access, and thought about like mechanical circulatory support, CV anesthesia support, of course, our guide wire selections and all of that. But I think one of the major things is we really want to make sure that the lesion is adequately prepared before we lay in our stent for optimal technical outcome. So the first thing I think to assess within this lesion preparation step is to make sure that we understand the calcium burden. If you have angiographic evidence of calcium, then you really should clue in that this may be a little more complex than just your regular type A lesion, that you can just do a pre-balloon with a semi-compliant stent and then NC for post-dilation. And maybe consider upfront use of intracoronary imaging, like with IVUS, which is ultrasound, or OCT, which is with infrared light. This is a paper that was just published this year under JACC that talked about best practice summary for use of intracoronary imaging, and the role of these imaging techniques really have it's really expanded and really have a lot of benefits it could bring to our interventions pre-PCI in terms of pre-intervention assessment. Like we want to assess for plaque composition, we want to assess for the calcium burden, we want to really quantitatively look at how big is this the stent should be, and also for stent sizing and the length. During the lesion preparation, we can look at successful lesion preparation, like successful fracturing of the stubborn calcium plaques. And then post PCI, you can look at how well your stent is deployed. So are there any under expansion? Are there any malapposition? Are there any edge dissection that you might have missed on angiographic imaging? And then any geographic misses. What are the data out there, particularly in complex PCI? There's the Renovate Complex PCI trial that was just published this year in New England Journal of Medicine that looked at IVUS and OCT guided versus just your regular angiographic guided complex PCI. And you can see the definition of complex PCI down there. Essentially, it showed definitely there's a benefit. There's less target vessel failure in terms of composite of CV death, target vessel related MI, and target vessel revascularization, 7.7% versus 12.4% for just your regular angiographic guided PCI. This is the third large trial in this realm, and it's focused on complex PCI, and it also includes OCT, which is about 25% of the patients in the imaging group. This is a New York PCI registry that had about 44,000 patients that looked at IVUS use versus just a regular IVUS use in these people that underwent PCI, and it showed midterm mortality benefits as well as midterm less target vessel revascularization. Interestingly enough, even with the growing pile of evidence showing that IVUS is superior compared to just regular angiographic guided PCI, the usage of this is still relatively lower, although it is increasing from 13 to 16% from 2014 to 2018, I believe. But it's still underutilized. What we're waiting for in the pipeline is the Lumium 4, which is a trial that will look at angiographic guided PCI versus OCT. So we'll take a look at that. And the primary outcome that they want to particularly look at is 2-year rate of target vessel failure. What we did with is IVUS. So you can see, basically you can see in the mid-LAD, very calcific disease, almost essentially concentric calcium. And in the bifurcation wise, you can see our left circ stent coming in, left circ guide wire coming in, and the osteo left circ is actually okay. Give it a second, I'll just play again. And then the distal left main showed, oh, hold on, there it is. So the circ is okay. And the distal left main showed that right after the bifurcation, there's a tight calcific spot. And actually the whole vessel is just really, really calcified. Now that we know that there are some high risk calcium features in our vessel, it's time to select our tools. In my mind, I organize this as balloon base versus atherectomies. So for balloon base, we just have our regular NC balloons, which you see here, the Euphoria and Trek. There's also this Swiss medical group has this OPN high pressure balloon that you can inflate up to 35, sometimes even 40 ATMs. Small case series are available, and it was a pre-market approval was obtained from this group in 2022. We currently have limited experience with these. There's also the specialized kind of balloons, a cutting balloon, which right here is Wolverine cutting balloon that has a little blaze on the sides, 3 or 4. And then scoring balloons, which have these like extra wire here that essentially it focuses the force of your inflation that allows you to go up at a lower inflation instead of the high, 35 ATM, lower inflation that deliver these forces kind of and these particular scoring or cutting edges. They are more bulkier to deliver, as you can imagine, and there is a clinical trial that compared the cutting and scoring balloon compared to rotational atherectomy, which I'll go over in just a second, but essentially showed that they're less likely to succeed, 81% versus 92%. But if you're able to get that in there, at 9 months, the results are similar. Intravascular lithotripsy is also a balloon-based tool that we use. This is the Shockwave. This is developed just here in our backyard. This is the newest kid on the block, and it's probably the most expensive one on the block. There are the Disrupt CAD studies. I think now have 600 plus patients that show that 92.4% success rate, and the flow-limiting dissection and perforation is low. So very promising, but are limited, there's obviously limited long-term data. The issues are deliverability. You still have to deliver these balloons down there. There are these shock topic, which when we deliver these ultrasound sonic sound, you worry about ventricular ectopies. You definitely want to warn the anesthesiologist, and it's like, hey, these are just your pacing spikes. They're not the real ones. These are just artifacts. And of course, I mentioned they're expensive. These are, because the ultrasonic waves that these balloons deliver, they are for superficial and deep calcium. This is a different case. I just want to show you, Dr. Tremolo and I did these balloons in real actions. I don't know if you can see this well on this. I hope you can, but there are these little these little crevices here that show the calcium plaques there that are really constricting. But then after a couple of shocks, you can see the balloon expanded nicely. This was the lesion before, you can see here, and then we have a satisfactory result after this. Rotational atherectomy has been a while for a long time, but previously it's called Rotablade, I believe, with the foot pedals, and now it's RotaPro, maybe a little bit easier to use. Basically, is these diamond encrusted olive shape kind of like burr that just drills down. You have to have a special wire, RotaWire, and it rotates at a certain speed, 140 to 220,000 RPMs. Some complications you want to worry about is the burr entrapment. So like this can get stuck, RotaWire fracturing, no flow, slow flow, AV block requiring pacing. Historic data have shown that it's up to like 9.7% complications, but the more recent data have shown that in high use, experienced center is actually quite low. The 3 trials that are associated with this is the COBRA trial, which unfortunately didn't show any different compared to balloon base. ROTA-X, which looked at people with and without rotational atherectomy. Of course, people with rotational atherectomy are more likely to have successful interventions, but longer fluoral time because you do have to set this up. No difference in procedural risk, but at 9 months, actually show instant late loss was a little higher, which makes you wonder that all these drilling might cause some endothelial damage that can set up a substrate to future stenosis. The Percutaneous RCT trial, which I already showed you, it showed that it's more likely to succeed than your cutting and scoring balloons. So basically, I think of this as a, if you really just can't pass anything down, it's a long lesion, calcified lesion, especially superficial lesion, then it's a facilitator that it can create a pathway for you and you can put some other stuff down there. This is a case that Dr. Lee and I did just last week for a right-sided, really calcific RCA, and then we see a very good result, a lovely result. Orbital atherectomy by CSI Diamondback 360. This is basically also a diamond encoded crown, and it basically just rotates in an elliptical shape, and it just depends on how slow you move this and the speed, 80 to 120,000 RPM, that you have this differential sanding. Advantages is that you can sand going forward and backwards, and you still have the continuous blood flow during the ablation, and you, like I mentioned, you can control the centrifugal force and depth of the sanding. Disadvantage is that you worry about vessel perforations, you know, especially for tortuous vessels. The Orbits trials have shown that the perforation is about 1.8%, is a little bit higher compared to the rotational atherectomies, which is about, I think, 1.2%. But the slow flow, no reflow, is a little lower. What we're waiting for is the Eclipse, our randomized control trial, that will directly compare balloon atherectomy versus orbital atherectomy. And then we have laser, excimer laser, which is basically this laser that's short wavelength, high energy UV lights that break down carbon. And also the generated heat can break down cellular debris. It has this unique niche. It's limited use here. We actually have to wear special glasses for the operators. The company warned you maybe this is not for calcific lesions because it has inconsistent delivery of UV light and increased vessel dissection. But sometimes in the past we have used it for, you know, CTO recanalizations, but mainly this is used in you know, intracoronary thrombus, no reflow, and under expanded stents. This is a patient that we did a while ago with Dr. Kane. He had no reflow after a stent placement, and we really just got to get down there and restore flow. And we were able to at least restore flow for our next step. The Euro 4C PCR group just met May 19th, so 2 weeks ago in Paris, and they developed a consensus statement. And this is just for your for your reference if you're interested. But these are the tools that I talked about and the best case scenarios for using them. And this is kind of just a tool selection in an imaging format. But for example, you want, you know, for like rotational atherectomy, maybe for lesions that are uncrossable lesions, long segments of lesions, and then especially superficial nodular tight calcific stenosis. And if you don't have to worry about side branch protection because you don't want to have another wire down there, you can potentially sand the side branch wire. For IVL, maybe for superficial and deep calcium, and the ultrasound can kind of break deep calcium. For large vessels, and then if you do need to protect the side branch, and then for the cutting and scoring balloons, you know, you might want to consider, you could consider using after the atherectomies. And of course, this is not, you can just pick one, you can pick a combination of it, depends on your specific patients and their lesions. So for example, you can do rotoshock, or you can do IVL with NC balloon afterwards. So for our case, that's what we did. We chose IVL with shockwave, and then we went back with NC balloon. And then we did IVUS again, just to make sure that this is, you know, for sure that it's cracked. So you can appreciate the cracked calcium here from prior, which is the concentric calcium. We laid down some metals. And then we did an IVUS optimization of post-PCI dilation. You can see down here. And this is our final result. And IVUS showed that we have a well-expanded stent without malapposition or edge dissection. So in summary, the three things that we talked about today is for protected PCI. The evidence is, not the most robust. It has not shown long-term mortality benefit, but it definitely can help us during our procedures, and I think it's reasonable in specific populations. Intracoronary imaging and complex PCI, I think the resounding answer is yes, there's a growing pile of evidence. We're waiting for the Illumium 4 trial for OCT-guided versus angiographic-guided PCI. And then lastly, just methodical approach to lesion preparation, thoughtful selection of tools. This is just an algorithm that the Euro4 CPCR group that published, well, actually it's not published yet, but it's accepted for manuscript, that basically just went through what I talked about.